you'll feel like, yeah, I could see these things in clinic and I feel more comfortable if I had to manage these things. And we all manage things a little bit differently. It's still very artful. Some of us maybe feel very comfortable with culturing an ulcer. Some of us may say, no, I'd like to refer that out. That's totally fine. I think that you'll see as I talk about these things tonight, I'll try to lay it out there on how should we manage these patients? What's the proper way to consider managing these patients? And maybe there's times where you get a colleague involved or someone else that you work with on a daily basis. You saw my financial disclosures earlier, so we're going to jump right into it. So first, we're going to talk a little bit about corneal dystrophies. And keep in mind with dystrophies, these are bilateral conditions. They're genetically determined. The layer of the cornea matters. They're not inflammatory. You don't see neovascularization with these types of things, and they're typically not associated with systemic disease. There's one that we'll talk about tonight that is, but typically they're not. And if you think about dystrophies, as long as you know that third bullet point, the corneal layers, it's going to make it a lot easier for you to be able to diagnose these things. And this goes back to our basic first year in optometry school, learning the anatomy of the cornea. We look at the epithelium here, Bowman's layer, the stroma, Descemet's membrane, endothelium. You all know this. This is just review. But I bring it up because the key with these dystrophies is knowing where that dystrophy affects the cornea. It allows for differential diagnoses and makes it easier to determine what we're looking at. And it helps with treatment strategies as well. So here's the first case. This was a patient that came in, 73 years old, complaining of really trouble driving at night. Didn't feel safe driving at night. You can see her best corrected visual acuity was about 20/30 in both eyes, and she brightness acuity tested down to 20/80 in the right eye and about 2100 in the left. She had some mild epithelial basement membrane dystrophy, which we are going to touch on here in a little bit. And she also had some cataracts as well in both eyes. Here's what you see on slit lamp. And it's really key when you're looking for this particular condition and you're all diagnosing it right now that you got to crank the slit lamp up a bit. You got to be specifically looking for it. I would tell you that probably this is the condition that's most missed in my clinic by our externs and our residents. And it's because at times we get caught up in the magnification not being high enough. You need to crank that mag up to find this particular information we're trying to find, which is guttata. I think all of us probably have that by now as you look at this. So this patient has a lot of guttata on the cornea. You can confirm it. You don't have to, but in our clinic, we confirm it with an endothelial cell count, a thickened cornea. You can do that with pachymetry. You can do it with a tomographer. And this patient had significant guttata present along with a cataract as well. So we have a patient that has a visually significant cataract. They have definitely visually significant Fuchs dystrophy. I tell patients all the time, if we just treat one and we don't treat the other, you're not going to be happy. If we just took your cataracts out and ignored what was going on with your cornea, you're not happy. If we fixed your cornea and left your cataracts, you're not going to be happy. Now, there's times where we do that. For example, a patient that maybe wants to have an advanced intraocular lens. We will then stage it. We'll do the cornea transplant first, and we're going to touch on cornea transplants here in a second, and then come back 3 to 4 months later and consider doing the IOL if they want a trifocal or adjustable lens. Now, if there's someone that is very comfortable wearing spectacle lenses, then we do these procedures combined. We'll take the cataract out at the same time, as you'll see with the surgery here in a second. We will do the cornea transplant. So how do we fix Fuchs dystrophy? What is the treatment for Fuchs dystrophy? Well, it's typically, depending on the surgeon, either a DSEK or a DMEK, a Descemet's stripping endothelial keratoplasty or Descemet's membrane endothelial keratoplasty. And as you can see here, the removal is the same. So the surgeon will remove Descemet's and endothelium with either procedure, but what's put back in is really the key. With DSEK, posterior stroma is put back in along with Descemet's and endothelium. When we think about DMEK, it's just really Descemet's and endothelium. And this matters what's put back in. Many surgeons are transitioning to doing DMEKs exclusively, mainly because of better visual acuity outcomes, as you'll see here in a minute with some of the data, as well as not affecting the anatomy of the cornea as well. And you'll see that here in the next slide. DSEK, they stick a little bit better. They don't detach as often in the postoperative period. Why? Because that posterior stroma sticking to stroma on stroma is very sticky, and so DSEKs detach less. But many surgeons transition to DMEC. I will say now there are DSECs that are being cut thinner. And so there are surgeons that are doing thin cut DSECs because of the anatomy being much thinner. But look at the difference here when you look at a DMEC on the top versus a DSEC on the bottom. Now, these are both detached grafts. We don't want to see this. This happens. We'd love to not see it detached, but to show you the difference in the graft thickness and why I say, boy, this can affect visual acuity. You look at that. Look at how the anatomy is going to change with the DSEC on the bottom versus a DMEC on the top. And we see this in studies. This was the tortoise study looking at visual acuity, DMEC versus DSEC, DMEC in the blue, DSEC in the yellow. You could see by 3 months that DMEC outperforming DSEC on the logMAR, but visual acuity as well there. And then at 6 months, you're seeing on average around nearly 20/20 vision with DMEC, more like 20/40 vision or so with DSEC. Patients still will say, even with the DSEC, that their visual quality is so much better. And I think that's really important with these types of patients. They're typically still seeing pretty well on your charts when you're checking their visual acuity, but their quality is what is not good. A lot of these patients will complain of nighttime driving. In the rain, it's rough for them. So the quality of vision really matters. I listen closely to that. I'm more than happy to recommend a DMEC for a patient that's seeing 20/25 if they are frustrated, if they struggle with those things driving at night and rain, because I will almost guarantee you that quality of vision will be better. They may even still see 20/25 after the DMEC, but the quality of the vision is really what matters. And we think about acuity versus quality, and both those things matter, and you want to listen to your patients in those particular situations. Adhesion in the postoperative period, you can see here DMECs detach a bit more, almost 10% of the time versus DSECs in this particular study. And so that is one postoperative piece that we have to address, or sometimes we run into with DMECs versus DSECs. This is the surgery being done, sped up, of course. This is scouring of the sick cells. So he's going to remove or pull out the endothelial layer. You'll see it right here. There it is. Endothelial is gone. Pressure is lowered in the eye. They inject the graft. This is a DMEC. And now to unscroll it, the pressure is really low in the eye right now. They can't touch the graft, so they have to do it from the outside, not go inside the eye. Unscroll it. The graft's in there. And then they inject SF6 gas. Sometimes they'll use air. The pressure will increase, of course. And now that bubble will press up and hold that graft in place. The patient typically for the first 24 to 48 hours will lie more reclined or on their back to allow gravity or to allow gas to rise and push that graft into place. And on day one, this is what we want to see. We want to see a graft there. We want to see a bubble there. We want to see a inferior peripheral iridotomy there. Many of you may not be seeing one-day post-op DMECs. Some of you will be, and I don't think it matters either way. A lot of surgeons want to keep their post-operative cornea transplant patients for the first day, the first week, sometimes the first month. This would be a one-day post-op. That bubble will dissipate. It'll be gone at about a week. These patients likely will be back in our chairs by 1 month, and we'll be managing visual acuity. We'll be managing new spectacle lenses, maybe contact lenses. And then I think the most important thing as optometrists that we need to manage in transplant patients, DMEC, DSEC, is corneal rejections. When do we know that the graft is rejecting? Now, we know with DMECs and DSECs, the percentage is low, but we'll run into this. And these patients are often asymptomatic. They may present into your clinical chair with no symptoms at all, except for sensitivity to light, decreased visual acuity. And what you'll be looking for is, number one, is there any corneal edema? Number two, are there any keratotic precipitates? If you see KPs, keratotic precipitates, plastered to the back of these types of transplants, or you see some corneal edema, you might be thinking, hey, could it be herpetic? Maybe, but in the setting of a graft, quite often that's a sign that graft is likely rejecting. And the way that you want to treat that is, yes, you could give the surgeon a call, but pound this eye with steroid. You want to hit them 8 times a day with a steroid for a couple of weeks. A lot of times, if you catch this and you see this, you can turn this around fairly quickly. With that steroid, you would taper it over time, and you can help these patients, and they can avoid having to get a new transplant. One of the exciting things for the future is this new IOTA cell therapy, where they're actually taking donor corneal tissue. So they're using cultured human endothelial cells. They're growing them in plates. They're mixing them with a suspension of ROCK inhibitors and some other types of substances. They're then culturing more of these types of cells. They then inject it into an eye that needs it. Once it's injected, the patient then sits in a prone position, so face down for about 3 hours to allow these endothelial cells to settle, and then those endothelial cells will proliferate. The exciting thing about this is, number one Petri plate or one cultured human plate can treat 100 eyes. And in the United States, we're lucky. We have eye banks in a lot of places. Getting tissue is not a huge deal. But worldwide, getting tissue is very, very challenging and difficult. And so the exciting thing about this type of surgical procedure is a lot of people are going to be able to be helped worldwide. A lot of people with one of these types of plates, again, can treat probably 100 eyes. And keep in mind with this, what's really happening is the ROCK inhibition is allowing these cells to kind of proliferate after they've settled onto this patient's sick corneal endothelial layer. So really an interesting therapy that is still undergoing clinical trials at this point in time, but moving forward and very likely something we see in the future. Let's do a quick review of the most common types of dystrophies that we see. And I'm going to blow through this fairly quickly. This is going to be a rapid fire. So epithelial basement membrane dystrophy, a ton of different names for this, right? Anterior basement membrane dystrophy, MAP dot dystrophy, Cogan's syndrome, probably the most common epithelial dystrophy that we all see, usually increases with age. We see this in patients above the age of 50 typically, but not always. Keep in mind that symptomology for this can be all the way from they're not symptomatic at all to they're having foreign body sensations because they're getting small recurrent corneal erosions. We can see irregular astigmatism from this. And the best tool that you can use to determine if epithelial basement membrane dystrophy is affecting a patient's vision versus is it a cataract, is it the retina, is a hard contact lens. Using a specialty contact lens, if you put that contact lens on the patient's eye and they have EBMD and they see a crisp 20/20, you can feel pretty confident that EBMD is the problem. We want to manage that. How do we manage that? If I see a patient where I could put a hard contact lens on the eye, specialty lens on the eye, I get them to 20/20 and they have significant EBMD that's centrally located, a lot of times I'll recommend a superficial keratectomy or a PTK, phototherapeutic keratectomy, to kind of smooth that surface out, allow new cells to grow back, and really improve that patient's visual acuity. Sometimes it's not affecting their vision, but you're dealing with recurrent corneal erosions. Then the key is to identify the underlying things. You may have to put some punctal plugs in. You may need to see, do they have meibomian gland dysfunction? You want to treat the ocular surface in order to help them with those recurrent corneal erosions. And you can see the data here. 10% of EBMD patients experience recurrent corneal erosions. 50% of patients that get recurrent corneal erosions that are in your chair will have EBMD. And so managing the condition, understanding how much is that affecting this patient's visual acuity. These are your clinical findings. They look like someone took a fingerprint and stuck it on the cornea. So you can have microcysts, chalky patches, a combination of these MAP dots and fingerprints. So a very common corneal dystrophy that we all see. Another epithelial dystrophy, not as common, but Meesman's dystrophy. You can see the image over here on the right. They look like these tiny little cysts. Why would a patient come in and see you with this? One, you may find it on a routine exam, but two, these little cysts can rupture over time. And if they rupture, you'll get recurrent corneal erosions. And with recurrent corneal erosions, you'll have to manage that like you would any other recurrent corneal erosion, possibly a bandaged contact lens, depending on the severity of it, maybe an amniotic membrane graft. But always look for the underlying things. Is there MGD? Is there ocular surface disease? Is there lid problems? You want to always manage the underlying things first. Reese-Buckler corneal dystrophy. I have a handful of these patients. Why I bring this dystrophy up is it usually affects young people. The patients that I've had have been 16 years old, 17 years old. This affects Bowman's layer. Kind of looks like a honeycomb-shaped lesion. It's gray in appearance, a little deeper than the epithelium, but not quite in the stroma. Autosomal dominant, and really you just maximize the patient's vision with contact lenses, glasses. Highly recommend against doing a PTK or an ARC or a SK on these patients unless needed. Try to wait as long as possible because this will reoccur, and it will reoccur fairly quickly. And so you can imagine in a 16 or 17-year-old, if we can get them seeing okay with glasses, contact lenses, we'll want to sit tight. Now we move into the stroma, your macular dystrophy. I think the key with this one is the way that it presents in the cornea. This is a condition that will extend limbus to limbus. It doesn't just affect the central cornea. It extends limbus to limbus It's in the stroma. It will cause haze and it will cause scarring over time. This particular condition, oftentimes nothing you can do unless it's very anterior in the stroma, then maybe an SK, maybe a PTK. Typically, it's in the deeper layers of the stroma. So it's maximize the vision. This patient in the future, if they get terrible visual acuity that can't be managed, they may need a cornea transplant. But the key to diagnosis here is limbus to limbus. Why do I say that? Because the most common stromal dystrophy we all see are granular dystrophies, and they only affect the central part of the cornea. These are snowflake type granules, central part of the cornea. There's two different types. There's granular dystrophy type 1, which are just the granulars. And then there's granular dystrophy type 2, which is called avellino. You see the granular part, but you also see these kind of lattice line opacities that form as well. Again, a stromal dystrophy, it's a wait and watch approach, maximize their vision. Stromal, tougher to treat with PTK or SK, typically would lead to some type of transplantation. And then lattice, another deep stromal dystrophy. These little lattice lines, you can see it in the image here, and you'll see that in your handout as well. A deep stromal dystrophy that, again, you're maximizing the vision as best you can with contact lenses, glasses, holding on as long as possible before having to make a referral for possibility of a cornea transplant with that type of patient as well. And then the final dystrophy I want to share with you, not one that is super common, but this is the one where there's a systemic disease component to it. So Schneider's corneal dystrophy, there's these kind of small needle-shaped crystals. They're white, they're polychromatic. It typically is in the stroma and the deeper stroma. If you see this particular dystrophy or you question it, it's worth getting cholesterol testing for these patients. Typically, a patient that has Schneider corneal dystrophy also has a cholesterol issue, high cholesterol, and so we want to manage that, or at least catch it so their primary care provider can manage that as well. So that's Schneider corneal dystrophy, one of the dystrophies that has a component to it that is involved with systemic disease. We're going to keep moving along. So this was a 19-year-old patient, came in with a painful red cloudy eye, does wear contacts, but like all our contact lens patients, she said, I take care of them beautifully. I don't sleep in them, none of that stuff. But she had a foreign body sensation for a few weeks. She had went to the ER on a weekend. They had started some neopoly decks. She presented to our clinic with best corrected visual acuity of 20/40 in the left eye. And then this is what it looked like on slit lamp. Same image, just showing you it three different ways. She had a branching ulcer with a satellite lesion. She had some cells. She had some injection. You can see centrally located lesion. These are always scary looking when they're centrally located like that. And so when we think about something like this, what are our case considerations? What's really our next step? Ask yourself that. And then, do you initiate treatment? And really what the next step needs to be is, yes, you need to initiate treatment, but culturing has to be the next step. And maybe you're going to do the culturing or work with a corneal specialist, work with a colleague that's doing culturing. The key tonight for me is that you understand when you identify something like this, when you're looking at this, that you have some rules in place on when or when not to culture. And I'm going to go through that here in a second. But this is a lesion that has to be cultured because it's centrally located and a few other reasons that I'm going to talk about here in a second. And then if you're going to refer for culturing, maybe you hold on treatment because they get them in that same day. If you're not going to hold on treatment, we're going to talk about treatment here in a second on what I would recommend you initiate based on what the literature tells us. But culturing is essential. And for this patient, when we cultured them, I started a treatment, fortified antibiotics, that ended up actually being the wrong antibiotic because the culture helped me determine that this was nocardia. And because the culture results kind of pointed me in the direction of what antibiotic I needed for this patient, I was able to save this patient's cornea, save their vision with really minimal scarring, because with nocardia, the culture results told me amikacin is the right option. I went ahead and switched them off their fortified antibiotics to amikacin every hour, and we were able to help this patient due to culturing. So as I mentioned, I'm not saying, boy, you all have to culture, but I at least want you to think about the reasons when should you culture. And I really like to follow the 3-2-1 rule. That's the rule that was taught to me, and I followed it ever since I learned this rule. Really what it says is if you have a lesion anywhere on the cornea that's 3 millimeters in size or more, you should culture it. I don't care if it's peripheral or it's central. If it's 3 millimeters in size or greater, that patient likely needs a culture. If there's 2 lesions or more, they probably need a culture. So If it's peripheral and there's 2 lesions, I'd recommend culturing it. If it's centrally with 2 or more lesions, I would culture that. And then anything within 1 millimeter of the visual axis should be cultured as well. So the 3-2-1 rule would be the reason to consider culturing. And then there's 6 other reasons there as well. But the 3-2-1 rule, really the rule that I'd love for you to think about and take home tonight. There's a variety of different ways we can culture. PCR testing has become popular. This is really looking at the pathogen-specific DNA of the actual bacteria or the fungus or the herpetic condition. You can do a quick culture, which has been shown to be comparable to direct plating, or in some practices, they like to do plates. In our practice, we do both PCR testing as well as plates. We have found that we're able to pick up some things on plates because you're growing it that maybe the PCR isn't catching. Sometimes PCR catches it where plates don't. Keep in mind that the literature would say on plates in culturing that about 50% of the time, you're not going to get results. And so you're going to have to use your clinical judgment and your intuition around, do I treat this patient? How do I treat this patient? But the 3-2-1 rule is what you follow. And then these are the different culturing considerations around it. I do want to share some other things around ulcers that I put together with a good colleague of mine and friend of mine who I do this lecture with at times, Dr. Allison Bozong. When we look at clinical findings, and the location matters. If you have a lesion that's central, that is a immunoprivileged part of the cornea. There's no lymphatics there. There's no blood vessels there. I don't care what kind of lesion it is. If you see a central lesion, it's infectious until you prove otherwise. It's more likely virulent. Or if it's peripheral, it's more likely staph related, more inflammatory related. So the location matters so much. Central, infectious until prove otherwise. Peripheral, more likely to be inflammatory. The size of it, make sure you measure it. I mentioned earlier, if it's greater than 3 millimeters in size, we should culture that. This one is not. This is very peripheral. This was a staph marginal infiltrate. This was inflammatory in nature, needed to be treated with the steroid. Very small in size, very peripherally located. Think of the 3-2-1 rule. I'm not going to culture a lesion like this. We want to look at infiltrates. Are they there? Are they not there? Is it fuzzy or hazy borders? More likely to be fungal if that's the case. And then think about single or multiple. It goes back to culturing or not. This particular patient has 4 lesions present. One of them on the superior side there being a artifact, but really 4 lesions present here. I'm going to culture this. Now, it may turn out to be staph marginal, and I may eventually put this patient on a steroid, but with 4 lesions, they're not going to get out of my clinic without me culturing this. And then we look at stromal thickness as well. We're later going to talk a little bit about herpetic conditions. If I see excessive edema, more often than not, I'm thinking that is likely herpetic. Excessive edema, herpetic, less edema, infectious. Why? Because if it's infectious, typically that patient's in your clinic very quickly. There's not enough time for that thickness, that epideminous component to become present. Where herpetic conditions, they fester a little bit longer, and you typically see a lot more edema. So excessive edema differential, you're thinking herpetic, less edema, you're thinking more being of infectious. Finally, anterior chamber reactions, you're looking for that as well. You can have infectious conditions without an anterior chamber reaction. If you see a hypopyon like that bottom image there, remember there's not endophthalmitis, but if you look closely, the real problem is on the cornea, that big, large ulcer that is there. If you see KPs, for example, more often than not, that's not infectious. That's herpetic in nature, and that'll come into play later when we get into another case. So granulomatous KPs or KPs at all, to me, you're thinking herpetic in nature. That's kind of your differential, less likely to be infectious. And then pain. Critical question, a patient that has an ulcer like this one that you saw here on the bottom, they should be in a ton of pain. If they're not in a lot of pain, that doesn't really add up to me, and you're thinking more neurotrophic. So critical question, or you might not even ask them, you'll be able to see it, how much pain they're in. If it's less than expected, you may want to check sensitivity because it could be neurotrophic or herpetic. If they're in a lot of pain, it's probably something infectious. It could be acanthamoeba, it could be fungal, or it could be bacterial in nature as well. So we want to think about pain. Now, management and treatment. So when we think about management and treatment, fluoroquinolones, they've been around a long time. I will say to you, second generation fluoroquinolones can be great for covering epithelial defects. They're cheap, they're inexpensive, but I would not use second generation fluoroquinolones for infectious situations. Now, I will say, if you know for a fact that you're dealing with Pseudomonas, then ciprofloxacin is still a good choice to add to your fortified antibiotics. So I'll say that again. Pseudomonas, if you know it, you cultured it, you know that's what you're dealing with, ciprofloxacin, still a great option to use along with fortified antibiotics. If we look at our 4th generation fluoroquinolones, these have widespread coverage still. I would say, based on the ARMOR data, that besafloxacin would be your best choice. You always want to be aggressive with these types of things in infectious situations. So every hour these patients should be getting dosed, and they should be getting up at night and getting a drop every 2 hours at night. But besafloxacin, probably your best 4th generation if it's infectious based on the ARMOR. One other antibiotic I want to mention that can be utilized and has very good efficacy against MRSA, methicillin-resistant staph, is Polytrim. Very inexpensive, very cheap. I quite often will add that to my fortified antibiotics. And the number one fortified antibiotics that I use would be vancomycin on the left, covers gram-positive. On the right would be tobramycin, gram-negative. So those bottom 2 are the 2 that you want to get. These can be compounded if you have access to a compounding pharmacy, but there is a pharmacy now that produces these where you can buy these for your office. They come in one bottle. You can store them. You can have them on hand. Feel free to email me after my presentation, and I'm happy to share that pharmacy with you. But vancomycin, tobramycin definitely can be utilized and it's my choice in infectious situations. I almost always will start fortified first. If I'm dealing with Pseudomonas, I'll add Cipro to my fortifieds. If I'm dealing with something that I'm concerned isn't responding well to Vanco and Toby, I'll typically add Polytrim as well. But I'm dosing these every hour during the day, every hour to 2 at night until I start seeing these patients get better. And we learn a lot of this through the ARMOR trial. 5 bullet points here. I'm not going to read through each one of these. I kind of stressed some of the importance here a minute ago. When we think about besafloxacin, the 3rd bullet point, it's still the best 4th generation fluoroquinolone that we have. We know that vancomycin, the 5th bullet point there, being the best fortified antibiotic that we have against these bacterial types of infections that we may run into on the cornea. I do want to mention the role of doxycycline and vitamin C in situations where you may run into a cornea that's going to perforate or is very thin. I will typically start one or the other. I won't start both of these if I'm worried about a cornea that may perforate. I'll do vitamin C sometimes, 1 gram 3 times a day is my typical dosage. For doxycycline, I'll do somewhere between 50 to 100 milligrams twice a day. And I do it only if it's going to perforate. And the most common situation is this would be Pseudomonas. Pseudomonas is notorious for causing thinning cornea, perforations, and so I'll often start one of these 2 agents. And I'll stop it when we're past that risk. These aren't used to treat the infection. These are used orally to help with reducing, hopefully, perforation over time. Steroids continue to be controversial, but with bacterial types of infections, and I'll stress that's bacteria, steroids still serve a purpose. The SCUT study showed us some of this information, 500 eyes that were treated with moxifloxacin every hour while awake for 2 days. These patients were then randomized to either topical steroid or they received nothing. When we look at the 3-month data around the SCUT study, I'll really take you to the last 3 bullet points there. There was really no statistically significant difference in the vision in the steroid versus the placebo group at 3 weeks or 3 months, and no statistically significant difference in scar size at 3 weeks or 3 months. So one side of this would argue, well, I could start steroid fairly quickly. There was no statistically significant difference in their vision or their scar size. The other side would say, why do I even want to start steroids if there's no statistically significant difference between the 2? My argument is, number 1, you have your clinical experience, but 2, remember, these ulcers cause a ton of inflammation. And at some point, we got to calm down the inflammation. We also know in the 12-month data on the SCUT study that the trend was better long-term vision in the steroid group. And so my rule of thumb typically is when I get the ulcer turning the corner, when I see it getting smaller or shrinking, I will start steroid. I typically will wait usually 4 to 7 days before I start a steroid unless it improves significantly within 1 to 2 days. And I keep the SCUT study in mind, realizing that long-term vision is likely going to be better with steroid use. There was one type of bacteria where it actually got worse, and that was Nocardia. That patient we talked about earlier, I probably would avoid adding steroid for that particular patient due to the fact that this study showed that these patients could get worse. So in conclusion, you get to know these patients well. You're going to follow them every 24 to 72 hours. Treatment can last months with these patients, but you have to be very aggressive with your antibiotics if you're going to manage these. And really keep in mind that culturing 3-2-1 rule, either you doing the culturing or working with someone that's doing culturing. Early intervention is critical to prevent vision loss with these tough types of corneal ulcers. We'll keep moving along. So this is a patient that came into our clinic, and they could pop up in your chair as well, that had noticed a steady decline in their vision in their right eye over the last few months. This was an 80-year-old patient. They had mild primary open angle glaucoma. They had cataract surgery. They're on one glaucoma medication. Pressures look pretty good. Posterior exam did confirm that the patient likely had glaucoma, and we're just looking at the right eye here. They had a decline in vision, and then this is what your slit lamp exam looked like. So you put some vital dye in the eye. You can see that they have a lesion present, and it's fairly close to the visual axis. So this would be a patient that I likely would culture. What's interesting, though, would any of you, and would all of you, I'm asking you the question, expect this patient to have pain when you see something like that? And I think you all would say, yeah, I would expect this patient to be in a lot of pain. Now, I'm still going to culture this because of where it's located at, and we just talked about the 3-2-1 rule. But my mind goes to something different when I see an ulcer or a lesion, or in this case, it's actually an epithelial defect with no pain present. And of course, our mind goes to neurotrophic keratitis. We have to do another test, though, to prove that to ourselves, and that's corneal sensitivity testing. And that's really what I did for this patient. And I raked my cotton swab all over this cornea, and this particular patient had no sensitivity in all quadrants in this right eye. And so for treatment for me, there's a few things I did. In these patients, I want to maximize their tear film. So I inserted a punctal plug in the right eye. I started preservative artificial tears. I began Synendrimin, which is a recombinant nerve growth factor that I'll talk a little more about tonight, 6 times a day, a commitment. But when you see the data around Synendrimin, you will be impressed with it. And for stage 2 and stage 3, in my mind, it's my go-to immediately for stage 2 and stage 3. We'll look at the stages here as well. But you can use it in stage 1 as well. I started an antibiotic because I don't want a secondary infection when I have an open epithelium. But there's other considerations here as well, and we'll dive into those. I think that whenever I start Synendrimin and prescribe it, there's going to be a little delay in getting it. And so I will often use an amniotic membrane graft for these patients. But the key here is to diagnose it accurately, to promote tear film health, and then I think you'll see here with the data in a minute, I'm going to fight to get some Synendrimin for this patient, a recombinant nerve growth factor, 6 times a day for 8 weeks and manage them. Here was the 4-week or 1-month follow-up for this patient. You can see visual acuity improved fairly significantly. That persistent epithelial defect, not quite healed yet, but getting better. And we're going to continue doing the treatment here. The one thing I kick myself on and look back at this case is I probably should have stopped the bimatoprost or went to preservative free, because with bimatoprost, there's a preservative on there. I'm trying to heal the ocular surface. Stopping the bimatoprost in a patient with glaucoma for 4 to 8 weeks, I'm probably not going to lose any ground. I'd watch the intraocular pressure. And so getting less preservative on the eye, we all learned something. I learned something about my own case when I did this. Here's what they looked at their 8-week follow-up. And you can see we've now healed the persistent epithelial defect. I'm going to go ahead and stop the moxifloxacin. They've finished up their Synendrimin. They're going to continue taking the bimatoprost. And then for this patient, I'm going to continue to monitor them and really promote tear film health. Very likely going to start an immunomodulator, try to make sure that that cornea continues to heal, but we've cleaned up that persistent epithelial defect at 2 months. So neurotrophic keratitis, I will say I've never diagnosed a patient with NK without running into one of these etiologies. And I think that's critical, that the history that the patient presents to your clinic will really guide you in making a decision. This patient had glaucoma. This patient had been on a glaucoma medication. I think they also had cataract surgery. So they'd had some surgery. They'd had long-term chronic use. They had underlying ocular surface disease. All those fit with all these different bullet points. And so really keep in mind that likely if you're diagnosing NK, one of these things is going to show up. The most common things will be herpetic conditions, diabetes, glaucoma, and typically dry eye or some type of surgery. So those are going to be your top ones, but keep in mind this slide. I think it's really important. It really guides you of, do I think about NK or do I not? Because I've never diagnosed a patient with NK that one of these things has not shown up. Here's your classifications, and you want to classify these. Stage 1, stage 2, stage 3. Stage 1 being persistent epithelial erosions. Essentially looks like dry eye. You're going to misdiagnose NK for dry eye. I've done it many, many times. You'll diagnose it as dry eye. You'll treat the patient as it is dry eye. They're not getting better. It dawns on you that maybe I'm going to test corneal sensitivity. You do that, you figure out, boy, this is actually NK. Stage 1 looks a lot like dry eye. Stage 2, persistent epithelial defect, like we just saw a minute ago. Stage 3, now you're getting into the tough stuff. This is where stromal involvement is there, the ulcer, you have melting perforation. Typically, this is going to be a patient that has had a herpetic condition for a long time, or they've had a chemical burn, a limbal stem cell deficiency, something along those lines. That's going to be your stage 3. In clinical practice, most commonly, what do I see? I see a ton of stage 1 and enough of stage 2. I do see some stage 3. It's less common, but stage 1, stage 2 are the ones that are going to be walking into your practice. And stage 1 are the ones that are easy to misdiagnose. Your diagnosis is dry eye. If you're not getting improvement, think about corneal sensitivity testing. How do you do corneal sensitivity testing? I typically use a wisp of cotton. That's what I like to do. It's essential to diagnose NK. I typically test the central cornea first to see if the patient reacts. I will typically test the good eye first because I want the patient to feel it. If I suspect that the patient has NK in the right eye, I will test the left eye first to see how they react. Because then when I go to the other eye, it reaffirms, number one, to the patient that, boy, there's a problem here because I couldn't feel that. I really felt it in my other eye, and I can see the reaction as well. The challenge comes when you have diabetic patients, that it's a bilateral condition. You have to watch the reaction of the patient. You may have to test different quadrants to determine. So a wisp of cotton is very easy. Dental floss is an option. If you're someone that likes quantitative data, then a Cochet-Bonnet would be one. The longer the length, the higher normal the sensitivity. The shorter the length on Cochet-Bonnet, the less sensitivity they have. And then they even have automated ones as well that will give you quantitative data. I don't care how you do it. Just have it in your arsenal. You are quantitative, Cochet-Bonnet automated, great. If you're quick, you want to not deal with quantitative data, you just want to know, do they have sensitivity? Then think about using a wisp of cotton. These are some of the treatment considerations in NK. I mentioned at times, you may want to prescribe Synendromin for stage 2 and stage 3. That is my go-to. Stage 1, I may try to take a shot at that with corticosteroids, maybe autologous serum drops, artificial tears. The in-office procedures, all of us as ODs can do this. Bandage contact lens, amniotic membrane grafts, punctal occlusion. You can do tape torsaraphies to close the lid, trying to promote healing. We're trying to avoid moving to that third thing, which is surgical interventions. Surgical torsaraphies, conjunctival flaps, those types of things. Those are big procedures. In our practices, we want to utilize those topicals and those in-office procedures if at all possible. Amniotic membrane grafts, a great option. Almost all my patients with NK get this first. I'll use an amniotic membrane graft. There's data to support these in NK as well. If you do a literature search, there's some studies out there supporting these. Cryopreserved is typically where I lean a bit because of the data around cryopreserved. Dry membranes, you may have a preference for those, but these are typically my go-to out of the gate start with while I'm maybe prescribing Synendromin and waiting for that, or I have a stage 1 patient that I can heal with an amniotic membrane graft. Here's some of the data around NK and amniotic membrane grafts. These things work. Older studies, but you see 10 out of 10 healing, 100% healing rate in the one study. You see 8 out of 9 in the other one. And so don't be shy about placing amniotic membrane grafts in your patients with neurotrophic keratitis. Synendromin, many of you have heard of this drug, a wonderful drug for our patients that have a very tough condition in neurotrophic keratitis. With Synendromin, you have two different studies here. You have the Reparo study, or a European study, on the left. You have the United States study on the right. It looked at complete corneal healing, not an easy endpoint to hit, but complete corneal healing. Impressive when you look at the data. At week 4, 58% of patients had complete corneal healing in their Reparo study. 72%, so almost 3/4 of the patients at week 8. in the Reparo study. And then you look at the US study, over 50% at week 4 and 65% at week 8. And so these patients had this complete corneal healing at week 8. If you think about that, that means they couldn't have a defect. They couldn't have persistent epithelial erosions. It had to be completely healed. And so a drug that you can reach for in stage 1, 2, or 3 neurotrophic keratitis. And then here are some of your other considerations. I don't want you to forget about these. 20% serum, autologous serum drops, a great option for patients. And I will utilize this quite often in stage 1 types of patients and have had great luck with it. Don't forget about scleral lenses as a therapeutic option, especially for persistent epithelial defects. There's some great literature around using scleral lenses for persistent epithelial defects because of that beautiful reservoir that it can form if you fit it properly. And then still experimental, but some work being done on topical insulin. This does have to be compounded, but some of the data around this is impressive. This was a patient here that went on topical insulin. You can see the way that their defect looked, and then a month later, the way that the defect looked. So a great improvement in a persistent epithelial defect in this particular situation. Some other considerations around managing your patients with neurotrophic keratitis. The last 10 minutes, we're going to cover a little bit about herpetic conditions. So this was a 44-year-old female patient that presented to our clinic with blurry vision, photophobia. This was in her left eye. Her right eye, as you can see here, saw 2015. Her left eye not seeing very well at 2600. She did mention that she had taken some big pills about 2 months ago. And they kind of seemed to help, but they didn't really improve the condition 100%. You look at her intraocular pressure, 12 in the right eye, 14 in the left eye, pachymetry, 542 in the right, very swollen in the left eye at 684. And when you look at the slit lamp exam here, she had a perfectly round area of edema present. She had some gutata, it appeared, injection, and she had 1 to 2 cell or so in the anterior chamber. The other image on your guys' right, difficult to tell, but if you look really closely, she had some scattered keratotic precipitates. So this is classic for herpetic conditions. You have some corneal edema present. We talked a little bit about this earlier. You have keratotic precipitates. You have an anterior chamber reaction. It's only in one eye. This screams herpetic. The other thing we need to think about is, well, what kind of herpetic condition is this? Is this epithelial? Is it stromal? Is it an endotheliitis? Because the reason why this patient didn't necessarily get better is because a mistake was made. They treated it appropriately by giving her the oral antiviral, but this patient needed one other thing. She needed a topical steroid because we're dealing with an endotheliitis. This is a disciform keratitis. There's no epithelial involvement. And so this patient is not infectious. It's herpetic. The key clinical findings are the keratotic precipitates and the edema. We need to start an oral antiviral, but this patient also has to have a topical corticosteroid or she really won't get better because it's not epithelial in nature. And so this is how I treated the patient. 1,000 milligrams 3 times a day of oral valcyclovir, and then topical corticosteroid 4 times a day. And you can see in a week, drastic improvement in everything. Vision to 20/40, less edema. The gutata actually were pseudogutata, which you will see quite often in herpetic conditions. Keep in mind that when we think about our textbook treatment for herpetic simplex, we typically say, well, Justin, it's 500 milligrams 3 times a day. And you're right. But clinically, I don't mess around often with these types of conditions, especially someone that has it as advanced as this patient. I will bump up and do what we commonly see for a Zoster patient. I'll give them 1,000 milligrams 3 times a day. I'm very aggressive with that. It works better clinically. Could you start with 500? I think in a mild case you could, but don't be shy about doubling that and think about your Zoster dosages and using that even in your herpes simplex types of patients. So here's some of the key characteristics. If you see a unilateral red eye, you need to be thinking about HSV. I wish all my patients presented with a dendrite like you see on that image on the left. That was one of my patients, but rarely do they present like that. They present with a marginal ulcer, or they present like a disciform keratitis that you just saw there, or they present with small little dendrites on the cornea. But any type of unilateral red eye with edema, with KPs, you need to be thinking herpetic. Keep in mind that after the first episode, 32% of these patients have another reoccurrence within 1 year. That's a key number there. After first episode, 32% of these patients have a reoccurrence in 1 year. We'll talk about prophylactic therapy here in a little bit. 90% of the population has HSV1 by the age of 60. And so these patients will be walking into your clinic. Typically will be unilateral. If you see bilateral, it's very likely not HSV. There's something more sinister going on. Key to managing these patients, you want to identify where it's affecting the eye. So epithelial nature, you can have a dendrite, you can have a geographical ulcer, you can have something marginal. If it's stromal, you can see a keratitis, blood vessel growth into that kind of stromal inflammatory area. Sometimes it's epithelial plus stromal. We'll come back on treatment here in a second. You just saw a disciform keratitis, so that's endotheliolitis. And then neurotrophic, we talked earlier, HSV a lot of times can create neurotrophic situations, and so you're managing that as well. Treatment, here's your treatment. I don't care which oral antibiotic you choose, just choose one of them to treat these types of patients. We know from the HEAD study of the hepatic eye disease study that you don't have to choose anything topical unless you want to. We know that these agents on the left, the orals, reach therapeutic levels in the tear film. They will reach therapeutic levels in the tear film, so you don't have to choose something topical. My clinical experience has been, if I see a bad HSV keratitis like the one you're staring at right now, I like to do both, but you don't have to. When we think about epithelial treatment, you don't want to use steroid, just use the oral. If you have epithelial and stromal combined, you don't want to treat with steroid. If you have stromal alone, you want to just treat with oral and you want to hit it with steroid. So epithelial, don't use steroid. Combination of the two, don't use steroid, just orals. If you have stromal alone, you got to use steroid and you got to use oral antiviral. Endotheliolitis, you got to use steroid and you got to use oral, or the patient will likely not get better. Prophylactic, I will typically start a prophylactic dosage if the patient is reoccurring more than once on me. They will be getting one of these options for at least a year. And then I will typically, if it's HSV that's not epithelial in nature, they'll get a drop of steroid as well. And so, again, more than one reoccurrence, they typically have bought themselves a prophylactic treatment for 1 year. And if it's stromal or an endotheliolitis, they bought themselves a drop of steroid a day along with the oral for a year as well. So keep these treatment principles in mind. I kind of touched on each one of these. You always want to treat the epithelial disease first, pause on the stromal. Anytime you're using steroid in the setting of herpetic conditions, you really have to have an oral agent on board. These are your dosages again. And then keep in mind in reoccurring situations, some of these patients may be on a topical drop of steroid and an oral agent for the rest of their lives. I've had times where I've went full year. As soon as you take them off, it flares back up. And so they may need it the rest of their lives. One drop of steroid, one type of oral as well. The last 4 minutes, we'll touch on herpes zoster. Keep in mind with herpes zoster that this is really a combination or etiologically comes from, varicella, which is the chickenpox, or reactivation of shingles. It can really erupt anywhere on the body, but of course, for us as optometrists, we're going to see this when it affects the ophthalmic division of cranial nerve 5. Our goal is that we catch this at that kind of acute eruptive phase. Quite often, we're not going to catch the pre-eruptive phase because the patient isn't coming in. They're not feeling anything. They're not hurting. There's no problem. When we see them, we want to catch them at that acute eruptive phase. We want to prevent them from getting to that chronic phase, post-eretic neuralgia, which is really the worst thing about this. If we don't get this treated before the 90 days, often these patients are in significant pain for an extended period of time of their life. And so our goal, again, catch them in that in that acute eruptive phase, catch them before hopefully 90 days if they've come in, and then we can manage these patients, because once they've gone beyond 90 days, then you're dealing with things like amitriptyline, gabapentin. You're managing this with their primary provider. The neuralgia piece is really the part that's hard. Here's your HZV treatments: acyclovir, valcyclovir, famciclovir. These will be in your handout as well. This is for review. You want to get these patients on oral treatment as quickly as possible when you identify it as HZV. Keep in mind that herpes zoster ophthalmicus can present with a lot of other things as well. The key is you got to start the oral, and then you may manage the uveitis with a topical steroid, or you may manage the keratitis with a topical steroid. HZO, much different than HSV in its management. The key is getting something oral started. And then we have learned recently from the Z study, the Zoster eye disease study. This was a multi-center randomized trial that looked at suppression of herpes zoster. And what they did in this study is one group got valcyclovir 1,000 milligrams daily. Okay, this was after they've cured them or essentially gotten past that eruptive phase. They've had them on the therapeutic dose. And now they're saying, well, how do I prevent a reoccurrence? So valcyclovir 1,000 milligrams daily versus a placebo group for 1 year. And the goal here was to reduce recurrent and chronic ocular complications. And this is what the data told us. So there was a 26% reduction in worsening of the eye disease at 18 months. They saw a 30% lower risk of multiple HZO flare-ups. And so this helped also with the decrease in postherpetic neuralgia. And so now in my mind, when I think of a patient that has HZO or they come in with herpes zoster, I quite often and will going forward probably leave them on a prophylactic dose, as we saw earlier, a prophylactic dose. This is therapeutic, but prophylactic dose of Valtrex, which is typically my go-to because it's so well tolerated, and really comes from the Zeds study. And I would do 1,000 milligrams, just like what Zed said, for 1 year. Antiviral is very safe, typically. Obviously, if it's a patient that has kidney or other issues, health issues, you want to talk to their primary provider. But Zoster, the Z study, tell us, hey, valcyclovir very likely going to reduce some of the things that we're worried about from a reoccurrence standpoint. So there it is. I tried to end right on time, so I saved 5 minutes for questions. I know that was rapid fire. I planned on it being that way. Email me some questions if you have any. There's my email address, and happy to stick around for 5 minutes of questions.
Great. So one of the questions that we had was, say that you see a corneal ulcer in office, you want to start them on treatment ASAP. What would you start him on treatment and send him directly to a cornea specialist? The question was, my cornea specialist once told me they can't culture after I start treatment.
Yeah. So they can culture still. Obviously, preferably, I'm in a cornea practice. I would prefer to culture with them not treated. But if someone calls me, and I hope this would be the case in most places, these are sight-threatening ulcers. If they call us, that's a real emergency. And if you're not culturing, I probably wouldn't start treatment. I would send the patient in right away, and I hope they're going to see him same day. I wouldn't delay that. I personally think that there's got to be a way to get that patient in same day when you're dealing with a true bacterial ulcer. So to answer the question, no, I wouldn't start treatment if you're going to refer for culturing, just because you could affect the culture results.
Great. Is there any evidence on using a immunomodular like cyclosporin to help prevent graft rejection over time?
To help prevent graft rejection over time. There is some evidence of using cyclosporins to help with that. The dosage of it, I believe, in the study was much more than what we normally dose it. So, cyclosporins typically are dosed twice a day. You're making me dig deep into my mind of what that study was. I want to say it was 4 to 6 times a day was what they utilized it for. But honestly, with the way that transplants are done now, if we think about DMEX, DSEX, at 2 years, if the patient used the steroid like they're supposed to for the full year, it's about a 1% chance that DMEC is going to reject, 1 to 2% chance. PKPs, full thickness transplants, a little bit higher than that. So I don't think there's any necessary thing that you need to do. Once we get to 1 year, most often we're stopping the steroid on any DMEC or DSEC patient because the rejection rates are so low.
Okay.
That's a great question, though.
Probably the last question that we'll have time for. Do you do the prophylactic oral for herpes zoster of the eye, not involving the cornea, just dermatitis for the decreased risk of postherpetic neuralgia?
Now that the Z study has come out, I do. I don't know if all my colleagues would agree with that, but I feel like it's such a safe medication, valcyclovir. at 1,000 milligrams once a day for 1 year. I have started doing that, again, basing it off of that particular study. I think that if you have one or two patients, if you ever had them with postherpetic neuralgia, they're miserable, and it is not a fun condition to deal with. And so the less that I can deal with that, the better. So I have gone to that now.
Okay, great. What the heck? Let's do one more because we have one more
Yeah.
minute. Any thoughts on ROCK inhibitors use in Fuchs dystrophy since it prevents cell death / promotes healthy cell proliferation?
Yeah. So I think that if you could try it. Um, I haven't had anyone necessarily get better with it when I've done it. I will say it's completely off label, obviously, which is totally fine. When you see a patient that's had a transplant, what's interesting, and you use just a ROCK inhibitor, again, off label, we're talking about a glaucoma medication because that's all we have access to. You actually can induce, and this has been published, like a honeycomb edema. I've had that happen a few times. And again, that's after a transplant's been done. But I have tried it in a few Fuchs patients with mild Fuchs dystrophy. Really haven't seen much of a benefit from it. Now, they are using it in IOTA. I showed that slide earlier, but it's a mixture of not just a ROCK inhibitor. There's some other components to it that they're using to proliferate those cells.
Okay, awesome. Well, thank you so much for your time and your sharing your expertise with us tonight.
Thanks for having me, as always. Appreciate it.
All right, good night. So please stay tuned for our time with Dompe, and we're going to get to hear from Dr. Kimberly Shawland on behalf of Dompe for identification and treatment of neurotrophic keratitis. Here is our QR code, so you can go ahead and open your OE Tracker app and get that credit for tonight's awesome CE presentation. Hello, how are you?
Good. How are you?
Good. Well, we're excited to hear from you. I'll go ahead and roll into your introduction if you're ready.
I am.
All right, great. Well, thank you guys for joining for our presentation. I'm going to introduce our next speaker, who is speaking on behalf of Dompe. So please join me in welcoming Dr. Kimberly Shawland from Green Bay, Wisconsin. As an optometrist within a multi-specialty ophthalmology practice, Dr. Shawland has a special interest in ocular surface disease and anterior segment pathology, with a passion for helping clinicians recognize disease at its earliest stages. Through clinical practice and education, Dr. Shawland is committed to increasing awareness, simplifying complex concepts, and promoting earlier intervention to help prevent disease progression and permanent vision loss. So we are excited to hear and learn from you, and I'll have you take it away from here.
Well, thank you so much. And of course, thank you to Dompe for having me. My name is Kim Shawland, and I have the honor of working within a multi-specialty ophthalmology clinic. So right in the same building that I work in, we have 2 retinal specialists, 2 glaucoma surgeons. We have a pediatric ophthalmologist, a oculoplastics ophthalmologist, and then 4 general surgeons. And so I started at the end of 2023 with the hopes of starting a dry eye clinic, and they blessed me with saying yes for that. But as you can imagine, with having those types of patients in the clinic, what I thought was going to be early dry eye was very quickly moderate to severe dry eye. And very quickly, with having the glaucoma surgeons and the retina guys right across the hallway, I learned that I saw a lot of neurotrophic keratitis. Of course, when we start in these settings, it's really exciting. In a sense, we get to see these stage 2 and some stage 3 NK cases. They make for cool presentations, but for those treating a lot of medical cornea, you quickly realize that you don't really want to see these patients anymore, in the sense that they're pretty devastating cases. You're talking about very sick eyes and often some level of vision loss that's permanent. And so with my experience, I just want to be able to share that so that we can find these diseases earlier and prevent them from going to these stage 2 and stage 3, where we're really seeing that vision loss. So we'll get started. Of course, Dompe is sponsoring this event, and I'm a paid speaker by Dompe. So really, what is this neurotrophic keratitis that we talk of? In school and a lot of the CE lectures, we're taught that it's staying without pain. So the patient walks in, blurred vision, and doesn't feel anything, and they have this wide open epithelial wound, or worse, a stromal ulcer or melting. And that's true, especially of the stage 2 and stage 3. And those patients are at high risk for vision loss. But we're in America, and we really want to talk about preventative disease. And, that's kind of the hype now, as it should be. And so really, what is stage 1 NK? Of course, any neurotrophic keratitis has to have some level of decreased corneal nerve sensitivity. But often in that early neurotrophic keratitis stage, we're seeing just reduced sensation. And to really understand this early NK, we have to understand the link between the corneal nerves and the corneal epithelium. And to understand that, we call it the neuroepithelial unit. And what that means is that the nerve and the epithelium are one. They are highly interdependent, and they only function optimally if the other is supporting it. Taking that a step further, how do they support each other, and really, how do they make each other function in that optimal level? The epithelium provides actual structure around the nerves. We know that the nerves come in at the limbus, and then they enter the epithelium, in which they are exposed or lose their nerve covering. And at that point, they're very vulnerable. And so they have to be protected quite literally by those epithelial cells. And just like anything else in the body, we have damage, and so we need some regeneration. And the epitheliums provide the road or the pathway into leading those nerves to their directed designation. In return, the nerves are the communicators for the epithelial cells. And so I kind of like to think of them as the foreman for the epithelium. They're telling one cell, hey, you're not connected to the basement membrane as strong as you should. Please tighten down so you don't slough off. They may tell the 2 adjacent cells, hey, you guys aren't tightly joined as much as you should. If you don't tighten that junction, then we might get some leakage. They may tell a cell, hey, we're not looking to do apoptosis yet. And then, of course, they'll tell all the cells, hey, time to regenerate. It's been 7 to 14 days. And so without one functioning optimally, it's not a matter of if the other is going to break down, it's a matter of when. And when we're talking about this early NK, we're talking about that beginning of the breaking down. And so that's really what we're looking for NK, stage 1. Of course, we know the Mackey classification as kind of guiding us in understanding the different stages of neurotrophic keratitis. We often see it being stage 2 and stage 3. So stage 2 is that persistent epithelial defect. And then stage 3, of course, is where we're having the ulceration or worse, the melts. So high risk for permanent, very quick advancing vision loss. But the stage 1 is where we're starting to see the epithelial change. And that's our clue into understanding that there might be a risk for NK. And so, in the Mackey classification, it talks about it being superficial punctate keratitis, which is the SPK. And so my hopes in, talking about neurotrophic keratitis and the early stages of it is that when we look at this stage 1 and we see staining under the slit lamp, SBK, PEE, however you have been taught or call it, the question that should come to mind is, how is the nerve doing? Because if we know that the epithelium, based on the corneal staining, is not functioning optimally, we know by nature and know that the understanding of this neuroepithelial unit that it can't support the nerves perfectly. And so we're talking, again, early stage NK, which is just that reduced sensation where the nerves just aren't functioning quite as we'd like them. And so that's really our 3 classifications, really emphasizing that stage 1, because if we can catch it at stage 1, we can avoid the vision loss at stage 2 and stage 3. And so identifying it officially, when we look at slit lamp or at any patient, we have 3 criteria to identify correctly any disease state. First, we have the medical history. So we have to have a reason why this condition could be there. Then we need the clinical examination. Specifically for neurotrophic keratitis, this is, of course, looking under the slit lamp. Do we have a persistent epithelial defect, or do we simply have corneal staining where we're seeing some SBK? If we see that, we should be asking the question, how's the nerve doing? And of course, we can only test or confirm how that nerve is doing if we test the sensitivity. And that's the third part, the diagnostic testing. So whether you're using the cotton swab, or the WISP, if you're using the dental floss, or if you're using something fancy like the Cochet-Bonnet, we diagnose and confirm this NK based on the suspicion from the medical history and based on the suspicion from the clinical examination through confirming that reduced or absent sensation with one of those 3 tests. Jumping back for a second on this medical history. So commonly, 3 things should come to mind for all of us based on our schooling, and that's the post-herpetic infection, it's the stroke, and the MS. Those are easy. If a stage 2 walks in, staying without pain, we tend to jump to those conclusions. Or in my case, right across the hallway from a glaucoma specialist, it's pretty easy to make that assumption as well. You can only take so many glaucoma drops and so many glaucoma surgeries before the epithelium breaks down. To that, I'd like to highlight, though, that I think we can really have an opportunity to diagnose earlier, especially this stage 1 NK, is chronic ocular surface inflammation and diabetes. Why chronic ocular surface inflammation? Specifically, why dry eye? There's many mechanisms of action into why dry eye leads to NK, but to touch on one specifically, we know that, well, first of all, we know that acute inflammation is always or typically a good thing. It reduces the threat or the risk to the body. It's the chronic inflammation that becomes the problem, and no tissue in the body likes chronic inflammation, including the corneal nerves. Chronic inflammation specifically reduces the secretions from the lacrimal gland, as well as it alters the meibomian glands, which ultimately leads to less meibomian gland secretion or a poorer quality of those secretions. When we have poor secretions, that leads to an unstable tear film. And that unstable tear film will negatively impact the epithelium. The epithelium cannot thrive if the tear film is not adequate. And if we know now with this neural epithelial unit, if the epithelium starts to break down, showing its face as epithelial staining, this SPK, we know that the nerve is at risk. And so when we see these chronic ocular surface conditions, specifically ones with inflammation, it's good to ask the question, how is that nerve doing? And then pull out our testing to see if we're finding some early NK. The other one is diabetes. Everyone in America knows that diabetes, if uncontrolled, can lead to neuropathy. In poor diabetic patients, we can see toes lost, we can see feet lost or limbs lost. That is classic neuropathy. But I think it's interesting that we're not regularly testing for NK, knowing that the corneal nerves are the most densely innervated in the entire body. We often are very accustomed to telling patients that if we see any diabetic retinopathy in the back of the eye, that this is a big concern for, showing that the condition isn't as well controlled as we think it is. And so in my clinic, specifically if I see any form of diabetic retinopathy, I'm questioning, hey, how's that corneal nerve doing? Because this systemic disease is no longer controlled like I want it to be. I'm seeing diabetic retinopathy. And I'd like to make sure that neurotrophic or that corneal nerves are functioning optimally. It's also very important, in my opinion, to check on diabetics earlier, because those of us who are treating a lot of heavy medical cornea, we all know that diabetics are very difficult to heal. And so catching these patients specifically in that stage 1 can really prevent a very difficult and long-term corneal case on our hands. And so I'll read this word for word. This is where oxervate comes in. The indication is oxervate, Synedromin BKBJ ophthalmic solution 0.002% is indicated for the treatment of neurotrophic keratitis. Important safety information includes the warnings and precautions. Contact lenses, whether they're therapeutic or corrective, should be removed before applying oxervate. Contact lenses may be inserted 15 minutes after oxervate administration. Eye discomfort, such as eye pain, that could be mild to moderate, can occur with oxervate. Patients should contact their healthcare provider if a more serious eye reaction occurs. Adverse reactions. The most common adverse reaction with oxervate, about 16%, was eye pain. Other adverse reactions with oxervate, ranging from 1 to 10%, included corneal deposits, foreign body sensation, ocular hyperemia, ocular inflammation, photophobia, tearing, and headache. So let's jump into what oxervate can do for our neurotrophic keratitis patients. Of course, studies bring us confidence and peace of mind whenever we're grabbing something to treat a patient. And so this is a 2 randomized, multi-center, double-masked, vehicle-controlled pivotal clinical studies, which when I read all of those words, I just remind myself that it's a well-controlled, well-established, well-thought-out study. So we have 2 studies. One is the European study, the Reparo study, and then the United States version of that. It's important to note that in this study, they only included stage 2 and stage 3 neurotrophic keratitis, which I think is important to highlight because we're talking about very sick corneas at this point. Follow-up was 48 weeks with the European and 24 weeks with the US. They both were dosed standard oxervate, which is 1 drop 6 times daily for the 8 weeks. And then the efficacy analysis was complete corneal healing defined as absence of staining of the corneal lesion and no persistent staining in the rest of the cornea at 8 weeks of treatment. Of course, the results are very impressive. So the European showed 72% hit that mark, and then in the American, it was 65.2%. This is phenomenal because you're talking about very, very sick corneas with a stage 2 and especially stage 3. And so when we're getting that high of a rate of complete healing, that's something to be said. Now, a lot of patients and a lot of clinicians will ask me about this whole recurrence thing, the 20% and the 14%. I have 2 things to say about that. The first is that, I'm expecting some recurrence because these corneas are so sick. For those of us who are being exposed to these levels of cornea, they're very difficult to stay healed just because when the cornea hits to this level of disease, you can never get it functioning optimally again. And then the second thing I would say is, grab the repeat treatment. Oxervate, I've used it multiple times on multiple patients. When we're talking about these patients specifically, there's usually a pretty strong etiology for their neurotrophic keratitis. So they're either diabetic, and we can't take away the diabetes, so we keep the risk for neurotrophic, leading to a potential breakdown of the cornea again. They may be glaucoma. I can't reverse those glaucoma surgeries, and I sure can't take away their drops, so the risk stays. And so I would urge just to repeat at that point, and that's what I do in my clinic, just because we can't let the epithelium keep breaking down, and so I'm not worried about that 20 or 14%. I treat a lot of stage 1 just because I can see what it turns into, so I would find it very exciting to see a study on the stage 1 and see what these numbers look like with that. So we already went over the safety of 1 and 2 point here, but for 3, oxervate may cause mild to moderate eye discomfort, such as eye pain. Patients should contact their doctor if a more serious reaction occurs. And then lastly, vision may be blurred for a short time after using oxervate. Wait until the vision clears before driving or using machines. These, of course, are second nature things to us, but they're not to the patient. And so, what seems not even worth noting to us is definitely worth noting to patients. A lot of my patients are Medicare patients, and so they're not working anymore, but I have had a very strong I think this one goes kind of down the middle of, a lot of people ask me, do I continue everything else? I will lean on the side that I say, no, we're going to stop everything, with some exceptions, of course. If they have glaucoma, severe glaucoma, we can't stop their drops. If they're a stage 2 that looks like it might turn into infectious, then I'm going to keep them on their antibiotic ointments and drops. But for the most part, I'm trying to get them off as many drops as possible for 2 reasons. Number 1, I need to simplify it for them, because we know that compliance is an issue for anything. And so if I can simplify it and get this drop in as directed, taking more off their platter is going to give me a better chance of getting that done correctly. And number 2, when we're using oxervate, obviously we have a risk for vision loss. And so, your standard ocular surface drops aren't as pertinent in this time frame. And so when you tell a patient that you can stop these drops for a short time while we're doing this important treatment, that usually perks them a little bit, and they are more compliant in that sense too. So I think it's twofold, but definitely it can be done both ways. And often, depending on the patient and the clinical history and current situation, they're not stopping any drop. So just depends. I'll read this word for word. Case overviews are of patients treated with oxervate in the pivotal clinical trials. Not all patients in the clinical trials achieve complete corneal healing, defined as absence of staining of the corneal lesion and no persistent staining in the rest of the cornea after 8 weeks of treatment. Patient overviews depict summary information only. Not all outcomes are listed, and individuals' results may vary. Evaluations of the images at baseline and week 8 were conducted by an independent reading center. So let's look at a case. So this is a 33-year-old female. Her left eye had the stage 2 NK have 2 high risk factors for developing neurotrophic keratitis. And you can see at week 8, we had complete healing, corneal healing, defined as that absence of staining of the corneal lesion and no persistent staining in the rest of the cornea at 8 weeks of treatment. So I have a question, and my question is, was this successful? And so from an oxervate standpoint, I would say 100%. It reduced the threat, it healed the cornea, and it did its job. So 100% successful for oxervate. But my second follow-up question to that was, is this successful in terms of us as eye care providers? And I would argue no. Because if you look at the top picture, we have some corneal haze. And if you look at the bottom picture, that's still there. Oxervate's job is not to reduce corneal haze. Oxervate's job is to heal the defect, and it did that successfully. But my question would be, if we found this patient earlier at stage 1, could we have avoided that? We don't have insight to what the vision was, so we won't know. But I would assume that some vision is lost. And so yes, success to oxervate. But for us, I think it's a missed opportunity, but I also think it's an exciting opportunity that we can find these patients earlier. We know that diabetic corneas are difficult to heal, so I'm sure that's why some of the haze is there. But, testing this patient a decade or 2 ago, we might have been able to avoid this altogether and treated it at stage 1. So just an opportunity for us to be on the lookout for earlier preventative medicine. So one more time for completeness sake, the indication, oxervate sonedrimen BKBJ ophthalmic solution 0.002% is indicated for the treatment of neurotrophic keratitis. Important safety information, warnings and precautions. Contact lenses, either therapeutic or corrective, should be removed before applying oxervate. Contact lenses may be reinserted 15 minutes after oxervate administration. Eye discomfort, such as eye pain that can be mild to moderate, can occur with oxervate. Patients should contact their healthcare provider if a more serious eye reaction occurs. The adverse reactions, the most common adverse reaction with oxervate, about 16%, was eye pain. Other adverse reactions with oxervate, 1 to 10%, included corneal deposits, foreign body sensation, ocular hyperemia, ocular inflammation, photophobia, tearing, and headache. And so I just say thank you, thank you for listening. And I just hope that if you can take one thing away tonight, it's just that if you see staining, simply spark the curiosity and ask yourself, how is that corneal nerve doing? And we can only know how that corneal nerve is doing by testing for it. Again, thank you for Dompe for having me, and I appreciate your time.